Good afternoon to everyone, regardless of where you're joining us from today. My name is Jeff Rafke. I'm the president of the American Institute for Contemporary German Studies at Johns Hopkins University. And we are delighted to have you here with us today for the second installment in a series we are doing on the impact of the COVID-19 pandemic on Germany and the United States in a comparative perspective. Our first topic in this series took place earlier this week, and it was on misinformation and disinformation and their relations also to extremism. We will be doing events and publications later on the economic effect of the pandemic. But today, we are focused on healthcare systems and the lessons for Germany and the United States. And I'm really delighted that we've got an esteemed group of speakers, both from Germany and the US, to help shed some light on these really crucial questions for public health in both countries. Now, among the things we will be producing during this series are webinars like this one, podcasts, as well as written analysis. And some of those are already up on our website, AICGS.org, and I encourage you to take a look at those. And I would also like to say one word of thanks before I pass the mic over to my colleague, Susanne Dieper, who is the Director of Programs and Grants at AICGS. And that is a thanks to our sponsor for this series. That is the Transatlantic Program of the German Ministry of Economic Affairs and Energy through the European Recovery Program. And with that, let me turn things over to Susanne, who will guide us through the rest of the event. Susanne.
Thank you, Jeff. A warm welcome to everyone from me as well. I'm delighted to moderate the second webinar in our series, The Importance of the Transatlantic Partnership in Times of Global Crises. As Jeff mentioned, we focus in this series on three different topic areas. And we're very fortunate to have three distinguished experts from Germany and the US with us today, who have looked at how the COVID-19 pandemic has impacted the two healthcare systems. And the pandemic, of course, continues to be a tremendous global challenge, with infection rates rising in some regions and a new variant that has emerged. But this makes a joint transatlantic effort to combat the consequences of the pandemic and to learn from each other even more important. It's my pleasure now to introduce our panelists. I'll keep it brief. You can find more extensive bios on our website. From Germany, Dr. Christina Arentz. She is a professor for health economics at the Institute for Insurance Studies at the University of Applied Sciences in Cologne. She previously was a senior economist and project manager at the Scientific Institute of Private Health Insurance in Cologne. She holds a PhD in economics from the Institute of Economic Policy at the University of Cologne. Also on the German side, we're joined by Dr. Ines Läufer, who is an in-house consultant for the Association of Municipalities in North Rhine-Westphalia. She holds a PhD in economics, also from the Institute for Economic Policy at the University of Cologne, and in the past worked as an economist at the German Federal Ministry of Health. Also, we're proud to say Ines was a DAD AICGS Research Fellow at AICGS in 2013, so it's great to have her back. Our US expert is Dr. Rebecca Emeny, who's a research scientist and teaching faculty at the Dartmouth Institute of Health Policy and Clinical Practice. Rebecca received her degrees from Cornell University and the University of New Mexico School of Medicine. She also spent time in Germany at the Ludwig Maximilians University in Munich and the Institute of Epidemiology at the Helmholtz Zentrum in Munich. Welcome to all of you. Thank you for being with us today. Our panelists will give their presentations, and then we'll open it up to questions from the audience. Please do type your questions into the Q&A function at any time, and I will read them out after the presentations. We'll start with our German experts, Christina and Ines. Please, the floor is yours.
Thank you very much, Susanne. I will share my slides with you. Okay, I hope everybody can see our slides, and due to the friendly introduction, I can jump right into that presentation without further ado. Yeah, what did we want to present to you today? Originally, Ines and I planned to give you some key insights of two articles that we wrote for AICGS. One was in January of this year and was about tackling the coronavirus in Germany, where we compared the first and the second wave. And then we wrote a second one at the end of summer about the challenges for the German healthcare system in the COVID-19 pandemic and beyond. But I must say that kind of both articles have been overtaken by reality, so that for today, we will focus on the current state of the pandemic in Germany because it's quite dramatic. And we will try to explain the factors, or which factors led to this situation we're currently in. So we will try to find answers to the questions, what went wrong and what can we learn from the current situation. Okay, to give you an impression of the situation we are currently in, here you can see the development of the daily new confirmed COVID-19 cases per million people since March the 1st in 2020. And if you focus on the German line, the red line, you can see that we have never had such high infection rates as today. And of course, only looking at infection rates or COVID-19 cases doesn't paint the whole picture, because given the existence of effective vaccination, those high infection rates wouldn't have to transfer in high hospitalization rates. Unfortunately, this is exactly what we currently see in some of the federal states in Germany. Hospitals already reached their capacity limits in the most severely hit federal states, so in the federal states with the highest incidences. And here you can see the development of patients in intensive care due to COVID-19 since August this year. And you can see the black line is the German average, and we have 3 federal states, these are Saxony, Thuringia and Bavaria, which have above average ICU bed occupancy rates and below average vaccination rates. So you have a correlation between low vaccination rates and high ICU bed occupancy rates. And since last week or the week before, we are in a situation where we have to transfer patients from those southeastern federal states to other regions in Germany, and even other European neighboring countries have offered to take on patients because we reach our limits here in Germany. What we also see is that mortality is higher in those federal states with low vaccination rates, because when you're not vaccinated, you have a higher risk of having severe complications when you contract disease. So now to the question of what went wrong, and I brought 2 indicators which might explain the situation we're in. First, the vaccination rate. We have about 70% of the German population who are fully vaccinated, but we have a pronounced regional variation, ranging from 58% in Saxony, in the federal state of Saxony, to 80% in Bremen. But given the Delta variant, even 70% is far too low. And then we have the second indicator, the naturally acquired immunization in the population is also relatively low, with 7%. So given those 2 indicators, decisive political action would have been necessary before fall and winter. Instead of that, we have seen that even the booster vaccinations for the most vulnerable groups have been neglected. So we are kind in a deja vu situation because we wrote in January 21 about 2020 that preparation for a possible second wave has been neglected throughout the summer, and the government has neglected to create or communicate a long-term national strategy. And sadly, now in December 21, we can say the same about the lacking preparation during the summer of this year. So why is vaccination so low? From an economic perspective, you can say that herd immunity, the herd immunity that we need to protect our healthcare system and to prevent general lockdowns, is a public good. And the problem with public goods is that everybody wants them, but nobody wants to contribute to the production of this public good. Yeah. So with regards to vaccination, the risk of vaccination, even if it's low, it has to be borne by the individual alone. But the benefit of vaccination is not only for the individual, but for the society. And the problem is that nobody can be excluded from the benefits of herd immunity, and this sets systematic incentives for free riding. And this is exactly the situation we are in. We have too many free riders in the German society who hope that others will get vaccinated, so they don't have to bear the risk of getting vaccinated. Of course, there are possible solutions to the public good problem. The first solution could be to alter the incentives for vaccination, to make it more costly not to be vaccinated. For example, by introducing rules that ban unvaccinated people from restaurants, from cinemas, from theaters, from various social aspects, social life aspects. Or by introducing a rule that you can only go to work if you're vaccinated, recovered, or tested. This is one possibility. Another possibility would be to introduce mandatory vaccination, so you don't have the choice, you have to get vaccinated. The problem in Germany is that altering incentives has not been effectively implemented or implemented too late. We have the rule for vaccinated and recovered, that only vaccinated and recovered people can go to restaurants in Berlin. We have had this rule, for example, in Berlin, but it was too late now in fall to implement those rules. And what is worse is that mandatory vaccination has long been excluded by politicians of all political parties. Yeah, the minute we had the vaccine, the politicians said, no, we won't introduce mandatory vaccination. So it was effectively ruled out, and it's only now, or 2 or 3 weeks ago, that we discussed the possibility of mandatory vaccination. What's more is that in a federal state like Germany, we have coordination problems when combating a pandemic due to our federal organization. As I already said, it was clear at the end of summer that the vaccination rate was far too low given the Delta variant. Now we have even Omicron. And nevertheless, we had no plans on no political level, neither in the federal states nor from the central government, as to how to respond to times when incidents would rise and how to respond to that situation. We had no plans made. On the contrary, vaccination centers have been abolished, and the legal status of an epidemic situation of national scope was also terminated in November, when incidence rates were also already high. Yeah? And this legal status gave the government the possibility to introduce stringent measures like lockdowns, school closures, etc. So why this reluctance to make plans and to introduce prevention measures? Yeah, nobody wants to be the bad guy, and there's no glory in prevention. pleading for more severe and preventive measures is politically unattractive in times with low incidences, especially in a federal system like ours, with competing players, with competing prime ministers of the federal states. And it certainly didn't help that we had general elections in September. So politicians didn't want to scare away voters by announcing more stringent measures for fall and winter. And we have been effectively leaderless since the end of September. So what lessons can we learn from these developments? Yeah, we can say that in a country like Germany, in a rich country with a really well-endowed healthcare system in international comparison, combating a pandemic is less a health system issue. Of course, the health system is currently deeply affected by the pandemic, but it is not the root of our problems. The root of our problems is more the lack of decisive political action, which aligns individual interests with the interest of the public. What we have seen in the last month is that politicians have shown much more consideration for the small but loud minority opposed to any stringent measures in the COVID-19 pandemic than for the majority. I have to repeat it, 70% of the German population is vaccinated, so it's a majority, but the politicians catered more to the small group, which is loud, and the majority has to bear the consequences now. And the problem with that is that this loud minority is driving infections in Germany. I'm sorry, is driving infections in Germany. A recent study by Meyer et al. From last month from the Humboldt University of Berlin showed that in Germany, 8 to 9 out of 10 infections are due to unvaccinated people. Yeah? So that without mandatory vaccination, Germany will probably keep running into hospital overload situations. Of course, all this is not to say that our healthcare system hasn't any problems. Yeah? We have structural problems, and we highlighted those in our second article for AICGS. First, we have a glaring lack of digitization on nearly all levels of our healthcare system, be it the public health system or the hospital system, with all negative consequences for treatment and prevention. And the causes for this low level of digitization can again be traced back to regulatory structures, to our federal organization, which implies that responsibility and funding are distributed among different political levels, so that this is a fact that hampers the coordination that you need when you want to have a digital infrastructure. And what is more, and perhaps the most prominent problem that we have in our healthcare system is that we have a high workload and difficult working conditions, even in non-pandemic times, especially for personnel in hospitals and in long-term care nursing homes. We have many hospitals, some of which are too small to operate economically, so we haven't an efficient hospital structure for one. And what's more is that the investment costs have been underfunded because federal states are responsible for funding investment costs in hospitals, and they haven't done that in the last years, so that the hospitals had the incentives to try to compensate these deficits from underfunding investment costs by generating more treatment revenues, and this led to a high workload for physicians and nurses in hospitals. And what is more, here's a lack of digitization again. You can only have efficient workforce planning within hospitals when you have digitization in place, allowing to deploy staff according to patient needs. And a prerequisite for this are electronic patient records, which have been introduced only very late in the German healthcare system. So these were the points that we wanted to share with you. We are happy to answer any questions later in the discussion, and or even if you have questions later on, you can contact us via my email, christinearentz@th-köln.de. But now we look forward to Rebecca's presentation and afterwards the discussion. Thank you very much.
So I'm sharing my screen now. Hopefully you all can see it. It is a real pleasure to be with you all today. Thank you very much to the organizers, Susanna and Elizabeth, for the invitation to participate in this discussion. This presentation is aimed to demonstrate, I think, two key issues that, from my perspective, have been highlighted in this nearly 2-year-long experience that we have been through with a global pandemic. Firstly, the importance of rigorous data-driven knowledge to inform evidence-based medical practice and public health initiatives. The map that you can see here is provided by my colleagues at the Dartmouth Institute using county-level data, a set of data that has been collated and coordinated by the New York Times since early in the days of the pandemic. And this map indicates just at the end of October, the COVID-19 related deaths per 100,000 residents of each of 306 hospital referral regions. And as you can see, the darker areas tend to be in more rural settings. And this is one of the main features that we have obviously witnessed in the course of the pandemic, is that it has transitioned from initially metropolitan regions to now we're witnessing more cases and subsequent death-related mortality rates in rural regions. The second very important point that I would like to touch on is the necessity of the measurement and the risk communication and management of social risk as much as biomedical risk to adequately manage an outbreak such as we are currently experiencing. We know that comorbidities make individuals more susceptible to infection by SARS-CoV-2, but I believe that what we have learned in this pandemic is that social risk factors are as relevant as those biomedical risk factors in protecting our patients and our populations. So those are the key points. What I wanted just to make clear here that I think everybody has experienced the Zoom world. I began teaching at my institution in 2019 to 50 very active minds of individuals who were engaging in a public health master's program at the Dartmouth Institute. And it is really the perspective of these individuals that has brought to my attention really essential aspects of what we are doing and what our role is in public health. We teach our students the 10 essential services of public health that revolve around 3 central activities. Number 1 being the assessment and the monitoring of health risk. Secondly, the policy development to inform, support, and strengthen approaches to mitigate harm and improve health. And all of that is to assure that efforts are sustainable in order to maintain a system in which all individuals can know and develop to their full potentials, which is a quote from a past American of Public Health Association President, Kamara Phyllis Jones. So it is with this framework that I will continue to look a little bit more closely at the numbers. When it all began, it's like taking oil to Athens. I regularly looked at the Johns Hopkins Coronavirus Resource Center for daily updates. What is fascinating, I think, in terms of a global case study is that the very first identified case in America was identified the same day as South Korea on January the 1st of 2020. And 3 months later, when I looked at the Johns Hopkins Coronavirus Resource Center map here, as you can see, the United States had 40 times the levels of cases of SARS-CoV-2 infection as compared to South Korea, which is down at the bottom of the screen here. So what was very clear from the onset is that public policies, messaging to the public about the risk of transmission of a highly infectious respiratory virus, all of those messaging campaigns were complicated and politicized and clearly differently managed in the country where I live compared to South Korea. When it started in the United States, after the first case was identified in January, it took 2 weeks for the first confirmed death to occur. The pandemic obviously quickly swept metropolitan regions, as I previously noted, and this map also displays sort of the exponential spread of the virus. It took the first 200 days of the pandemic in the United States for the first 200,000 deaths to be confirmed, and only 100 days for that amount to double up to 400,000 by the end of, or the start of January 2021. So where we are all at now is that we're almost at 800,000 confirmed deaths. We're at 778,000 as of last week. We have 74% of our population vaccinated, but currently in our region, as is happening in Germany, there is an uptick in both cases and mortality associated with SARS-CoV-2 infection. In my region, where you can see behind me 5,000 feet below in the medical center where we work, 1 out of every 10 individuals who are tested are testing positive. This is a 10% rate, of course, and that's up from 1% in the summer months. In the southern tier of New Hampshire, we have about a 20% test positivity rate in New Hampshire. Currently, we are serving 71 COVID patients in our hospital. So we are not at capacity because we are a rural center and largely vaccinated in this region. The Northeast is one of the most highly vaccinated regions, along with California and the Northwest. But there are vast pockets of America that, of course, are also still not vaccinated. So who was most hardly hit in this epidemic? This is data again from as well as from the last slide from the Vox Media article that just really digitally and graphically presents this sort of these beautiful digital displays of data, indicating that over 50% of COVID deaths were of people aged 80 or higher. But if you include anybody above age 50, that is almost 95% of all deaths have occurred in the older population. Also, it's evidence that people of color have died at 2 times the rate of white people. And what this really, really highlights, and was supported by a recent publication from colleagues at the University of Albany, in which neighborhood analyses in New York City at the peak of the pandemic demonstrated that COVID-19 related mortality was higher in older populations with higher levels of disadvantage and lower quality of health to begin with, which speaks to the aspect of social determinants of health that the World Health Organization determined in 2008 to be the conditions in which people are born, grow, work, live, and age. And they declared, the WHO declared in 2008 that identifying and improving these conditions of daily living is an integral aspect of achieving health equity. And it is really largely what I think has been demonstrated, that is these factors that have driven social risk and the social disparities that we have observed during the COVID-19 pandemic. So just to pull back and compare German and American experiences, again, using Johns Hopkins data, the plots on the top show the waves that we have experienced. The red arrow is when I was able to receive my vaccination, my first shot in April of 2021. I was shocked when I was speaking to German colleagues and they were not even aware of when they would be able to receive vaccinations. And I think it only really started to be rolled out in the summertime. That I thought was really fascinating to see how jumbled distribution processes were, comparing both our experience and yours. But I think what really stands out to me is the toll that this pandemic has taken on a global perspective. And the plot and the bottom of this graph, you can see that Germany is quite well off down here, where this is comparing the excess years of life lost through the COVID-19 pandemic compared to the flu pandemic in 2015. And there is a pretty equivalent rate of death between 2015 and 2020 for Germany, but America is over here with Russia and Bulgaria and Lithuania with an excess of almost 5 to 6 times as high life lost compared to past influenza seasons. And I think that can perhaps roughly be explained then in the final part of my presentation based on the distribution of medical insurance and how medical care is provided to populations in America that is very different, I think, in Germany. The main obvious difference is healthcare coverage. In America, the majority of individuals are privately insured. That is mostly through employment-based programs, as you can see in the pie chart here, which represents 82% of private insurance comes from worker-associated insurance plans. 30% of our population is covered by federal programs. If you are an older individual above age 65, you are eligible for Medicare services. And if you are living in lower income statuses, you are eligible for Medicare, federally funded programs, but Medicaid. The difference in these two programs is that Medicaid is largely state run, also federally funded, but largely state run and operated. Thus, from state to state healthcare management for low income individuals is dramatically different. But if you are an older person and you receive Medicare in California, it would be no different than if you received Medicare services in Alabama or New Hampshire. So this information is relevant because, of course, the burden of disease has been in older populations, and thus the federal government has shouldered the majority of the costs. On the right here, these pie charts describe the hospitalizations in 2019. This is data collected from a national, sorry for the jump there, a national hospital system that focuses in on hospital care, critical care, and they have been able to come, this data, I'm jumping ahead. This data here is provided by the Agency for Healthcare Research and Quality and is reported in their statistical brief just describing hospitalizations due to the COVID-related hospitalizations in 2020. And you can see that the large portion of hospitalizations is being handled and paid by federal programs. So jumping ahead to where I was going, what I wanted to describe was data that has been recently published by my colleagues from a national medical group specializing in hospital medicine, critical care, and emergency medicine, and using the data that they collect on both their patients and their providers, they counted the number of test positives for providers who had cared for at least 100 individuals over a 9-month period between March and December of 2020. And what they were able to demonstrate here is that providers who saw in a 9-month period between 20 and 50 patients, COVID patients, they were at a 2.7 increased risk of being infected themselves compared to providers who saw less than 10 patients with COVID-19. And if a provider was expected in that time period to care for over 50 individuals with COVID-19, they were at a 4.8 times higher risk to be infected themselves. So really it is this greater burden that has been shouldered by our healthcare workforce in America that really continues to be a major public health issue, not only for the providers, but for the patients who need the care. And a recent systematic review and meta-analysis demonstrated that globally, healthcare workers are reporting, half of healthcare workers are reporting PTSD, 40% anxiety, and about 37% depression or distress. So this is taking just a tremendous toll on our healthcare workforce, and that is a major problem for us to manage. Some of the factors that lead to this distress during COVID-19 is, of course, just the fact that they are constantly having to work. I have the privilege to work at home behind my screen all day in the comforts of my house. Many people who are on the front lines of care do not have that luxury. Oftentimes, the essential workers are economically marginalized themselves and putting their families and their communities at risk by serving patients that are coming in for care. And so what I think is really important to pay attention to moving forward is the promise of medical record data to be able to capture the social risks that our patients are facing. And in my institution, since 2011, the Dartmouth-Hitchcock Health System has had incorporated electronic medical records into their healthcare process. I would say the majority of all hospitals in the country have electronic medical record systems now since about that time. So we're going on about 10 years of experience with digitalization in our hospital system. And what has happened since 2017 is an effort to capture information on the social determinants, the risk factors that patients are presented with. In our electronic capture of data, patient data, we pay attention to literacy, employment, income, legal issues, social integration, food insecurity, housing insecurity, domestic violence, transportation, lack of transportation to care, and the access to phones. So telehealth, we all know, has served as a very promising approach to providing medicine or medical care to, or else at least consultation to patients, but that depends on phone service and the ability to financially afford phones. I was shocked when I moved from Germany to America to recognize how expensive it is to own a phone in this country. And so that is not a given that everybody either can afford a cell phone or coverage. I live on the other side of the state of New Hampshire in the hills of Vermont, and our town only recently got Ethernet and widespread access to phone coverage this past year. So access to phone service is also not a given in this country. So the collection of patient data on social determinants of health was mainly driven by a Medicaid managed service program. And then at the same time in 2017, our hospital took on a model of collaborative care to provide mental health services through primary care to our patients. And this collaborative care model is well evidenced through randomized controlled trials and many studies across many different medical settings to be very, very effective at connecting patients to behavioral health clinicians who are more accessible in the primary care setting than psychiatric consultants. This graphic describes here with the dotted line how inaccessible psychiatric services are to both patients and primary care physicians. But through the electronic capture of patient need, patients are screened with the patient health questionnaire PHQ-9 or the generalized anxiety disorder questionnaire screener at their initial entry visit and every 6 months thereafter for depression and anxiety. And if they indicate need, they are then bumped up into the being offered clinical care through these non-medically trained clinicians. So I think in closing, what is most prominent for me to say is that I believe that there are opportunities in training at the level of clinicians and public health professionals to recognize social risk as much as biomedical risk for susceptibility to disease. The other training area is in not only information technologists and data architects to collect data, but also programmers to manage the vast volumes of data that we have to make useful knowledge out of the information that's being captured, because I think many institutions are absolutely stymied by the overwhelming amount of data and how to manage the privacy issues of patients, which is paramount, the proprietary aspect of who owns the data, and largely it is the private companies that serve the electronic platforms to collect the health. The hospitals do not own the data, the software companies do. So that's a real issue to overcome. But then finally, that we need a global communal perspective that's driven in anti-racist and social justice sort of foundations of serving the public good to be able to protect patients and populations around the world, locally and regionally. So with that, I'm through with my slides. I thank you for your attention and welcome the questions that we hope will be coming in.
Thank you very much, Christina, Ines, and Rebecca. This was fascinating, and I will start off with a question first to Ines and Christina. So it struck me that you mentioned that coping with the pandemic is less dependent on the healthcare system, but it's rather a matter of decisive political action. And you know, at the beginning of the pandemic, Germany was much lauded for its universal healthcare system, paid sick leave, something the US doesn't have. And I remember noticing that the first death in Germany took a long time to occur. But of course that has changed. But are there any indicators that the excellent healthcare system in Germany does make a difference in fighting this pandemic? And then to Rebecca, has the lack of universal healthcare worsened the pandemic outcome in the US? So this is a question to get started.
Okay, so of course our healthcare system, we are very grateful for our healthcare system. The point that we wanted to make is that even the best healthcare system cannot cope with a situation where the population does not follow rules, or if we have no rules and the population gets infected at that high infection rates that we see now, even the best hospital system cannot cope with a situation like this. Because in normal times, we just cannot put all our resources into the healthcare system to have enough room for the patients in such a pandemic. So yeah, that's why we said that we are dependent on political measures, on decisive measures, which are then followed by the population.
And I think it also can have two effects. On one hand, population and people are quite careful because they are kind of trained, they know the risk of health or of disease, they get information, they have access. So at the beginning of the pandemic, I think people have also been quite careful because they got information, because our healthcare system provides information and tries to protect people. But on the other hand, now, for example, if you know that you have access in either way, so sometimes you get a risky behavior, and so you don't pay attention. So I think the healthcare system can affect the behavior of the population in two ways.
Thanks. Rebecca, do you want to comment on the US side?
Yes, so I think what's very important is that people with private insurance generally go to private hospitals that are very well funded and have the highest level of technology and treatment options. And what was very clear from the start is that not just when we were waiting for vaccinations, other measures such as the use of antibodies and other medications was very effective. And if you were privileged enough to be infected, if you were infected and privileged enough to be able to be serviced by good hospitals, you could manage the infection and not have severe COVID-19 or die from it. So I think the Medicare and the Medicaid populations are then serviced by hospitals that are not necessarily as well equipped, well funded, and therefore did not necessarily have access to those high levels of effective care. So that definitely impacted who suffered from the infection. I think that is the biggest issue, is that with a respiratory virus, it is going to continue to spread. And the misnomer that being vaccinated was going to somehow make you able to never be infected again. I think that somehow was messaged that once you were vaccinated, you were protected from infection and from spreading the infection. And that's absolutely not the case. As soon as people began getting vaccinated, the government said you don't have to wear masks anymore. And I think that was very foolish, because the biologic reality is the vaccines were actually FDA approved because they prevented severe COVID, not that they prevented infection. They have the likelihood to reduce the burden of infection, but vaccinated people themselves can be infected. And so I think it's being clear about what we understand and what we then put forward of knowing and how we're messaging behavior that has been very complicated, and many people have not been as my colleagues have said, decisive about clear messaging.
Yeah, I think that can be said for Germany as well. And again, at the beginning of the pandemic, I think Germany's public health response was very positive in terms of health communication. And that shifted, and I think it's in part because of the federal system in the different states, and everybody has different responsibilities. And just as in the US, there have been confusing messaging, messages, don't wear a mask, wear a mask. And do you see that, do you think that both countries have learned that messaging is important? It doesn't seem to be the case, but.
I'll say briefly, also to a point that Jeff has in the chat, I was impressed with our college community at the very start of the pandemic. They did reach out to the community and ask for input about what we as a academic community thought were important ways to message. And one point that I have been quite impressed by the impact of the insistence of social distancing. I know individuals who locked themselves into apartments and didn't leave it for months. And that's not good for anybody, let alone getting out and walking in the fresh air. They were scared to go outside their door. And I think that if widespread messaging had focused on physical distancing, the need to keep yourselves 6 feet apart from individuals so you didn't share airspace, these sorts of unified messaging may have been much more beneficial to general public mental health of our population as well.
I think they've learned that it's quite important, but they don't know how to align all those messages. So how to get a real communication strategy. I think that's not, until today, not a lessons learned.
And I think in the first, in the first wave, we also had the help by the pictures that we had from Italy. Yeah, these very impressive pictures that put the fear into the population, so everybody was cautious. And maybe our good healthcare system is also a problem, because now people think, okay, if I get the infection, I have access to hospital care and it's no problem. So I think that countries like Italy or Spain, or countries with a healthcare system that is more fragile, are now more cautious, and we see less infections and more stringent measures, whereas Germany may have been too arrogant now, because we coped well in the first wave, and we had less mortality than other countries. And now we see that our vaccination rate is not high enough to prevent the overstretching of our healthcare system. Yeah, but in the first wave, we saw decisive political measures, but of course, the politicians were also helped by the impressive pictures that we had from Italy. Yeah. So that was the most effective communication, having those pictures. Yeah.
Interesting. And then, as you mentioned, the election happened. So politics before policies, right? There's a question from Liz Hoteri. Rebecca described the economic and racial disparities in terms of healthcare and COVID infection rates in the US. Does the same problem exist in Germany? Is there data on these disparities that, people who live in more disadvantaged situations, maybe who have a migration background, were they more affected by the virus?
Yeah, we have seen that. In the beginning, we didn't have the data due to data protection reasons. So it was only until late in the pandemic that we saw that socioeconomically disadvantaged groups had higher infection rates and were more often in intensive care. So we have that problem here, also in Germany. Yeah.
Okay, and a question from Axel Spies. Can you please comment on the exchange of patient data for COVID research between Germany and the US? Are data protection considerations in Germany an obstacle for better research and COVID measures?
Yeah, our data protection rules are clearly more stringent and are a problem for data exchanges. Yes. Yeah. And as to the question if we have data exchanges with the US, I have to say I don't know that.
I think what's very helpful are clearinghouses like the Johns Hopkins Coronavirus Resource Center, they obtain their information from public, from county level, state level, regional level reporting. That is then collected and managed, and you can actually access that data for your own purposes if you're interested in digging in and running analyses. But they do a remarkable job, and you can spend hours looking at the way that you can graph and the way that you can analyze the information that they have collected from every country
yeah, okay. I thought it was about individual patient data. Of course, we have exchanges of anonymous health data.
Right.
I thought the question was regarding individual patient data. Yeah.
But those patient data restrictions are very, very tight in my institution as well. You cannot release any PHI, patient health information, without very stringent institutional review board review, and only when it's de-identified, doesn't have any personal identifiers in it, dates of service, dates of living location, birth, none of that information can be in the data set that you use. And our institution is really, really cautious in managing that.
On the transatlantic exchange question, I think the US typically follows waves of infections that happen in Europe after, I don't know, a couple of weeks or so. So we'll be seeing an uptick in infections, and I think we are already in, around Christmas time. Is that something that the healthcare authorities, researchers, government officials in Germany and the US are conversing about? Do you know if there's any exchange, any way to learn from each other about these waves happening?
As far as I know, I think there's a lot of exchange between the scientists and on an academic level, but I think in Germany, the issue is not question of having the knowledge or having the information, but it's really a question of doing it, of putting the right stringent measures and do some political regulation. So I think the exchange on knowledge is not an issue, and it's going on also between some German institutions and the US, but it does not have a good effect on political action. That's what I would answer.
Thanks. And maybe a final question. Are Germany and the US dealing with problems not only with healthcare providers leaving the profession, and that's definitely happening in both countries, but fewer people entering the field due to the decreased trust in the medical profession, overcrowding in hospitals, the burden that Rebecca pointed to in her presentation? Do you see that?
Well, I can speak from the students that I have observed. So some of the students seeking MPH degrees are already in a medical training process, and they take a year off to get a public health degree. Others are fresh out of college and intended to go to medical school, and then had experiences on the front line and said, actually, I want to get into communications, public health communications. And so that's really interesting for me to see how the next generation of healthcare motivated professionals will, with this knowledge of what's gone wrong, how can we do better, be seeking ways to improve not just the smart capture of knowledge, but the translation into what the population can understand, what motivates them to behave collectively. And I think that heavy-handed law can work to a degree, but you get a lot of resistance as well if people aren't on board. And I think that's what we're experiencing in both countries. The session at the beginning of the week of conspiracy theories was really informative in that regard. And so we really have to think hard about how to be convincing in what we know to be true to get everybody on board.
Yeah, so we see in Germany, we see people leaving the healthcare system, the hospital system. We have 3,000 ICU beds less than in the first wave, not because we don't have the beds, but because we don't have the personnel to operate those beds. So this is a development that is really scary, and we will have to improve the working conditions in the hospitals and in nursing care homes, where we also lack the personnel to get the people into the job. Yeah, this will be the most pressing problem that has to be solved in the coming years in the German healthcare system.
And there's here a comment to Rebecca. So we need a better communication and convincing strategy to compensate for decreasing doctors and nurses. So perhaps we can work together on that.
Maybe if the very final question, how do you think mandatory vaccination is coming in Germany?
Yes, they are discussing it now. They have discussed today the federal prime ministers and the incoming and the outgoing chancellor, and I think that mandatory vaccination will definitely come, because we don't see another way out of this wave, or the fourth wave. For the fourth wave, it comes too late, but we want to avoid a fifth and a sixth wave. Yeah. So I'm optimistic.
Yeah. Well, we've come to an end, unfortunately. Thank you, Christine, Ines, and Rebecca, for your presentations and insights. It was a fascinating discussion, great presentations, and I'm sure the conversation will continue. We'll have to continue. For our audience, I'd like to draw your attention to our project website. Christine and Ines, they've mentioned, have written 2 articles and 1 more recent on the topic, which you can download on our website. Rebecca's essay will be uploaded in the next few days. We will also record a podcast with 2 other healthcare experts on this very topic next week, and we'll publicize that as soon as it's been uploaded. Thank you for joining the discussion today. We hope to see you again soon at another event at AICGS, and please take care. Bye-bye.
Thank you all.
Thank you. Thank you. Bye-bye.
Bye.